So I think in the medical community, the first order of business was to really dig deeper and try to understand whether these findings could be reproduced. So that generated interest at other centers. So these were a series of papers that came out of an Italian multiple sclerosis center. So other centers sought to try to reproduce Dr. Zamboni's team's findings. So here are a couple of studies. One here in the United States, in the State University of New York in Buffalo. They had 500 patients, and this was a study where they used the Doppler test to try to find vein abnormalities in MS patients, people with other neurological diseases, and people without known diseases. These are the proportion of patients that they found the abnormalities with. So suggesting an increased frequency in MS, but not the dramatic 100% versus 0% finding that the Italian group had reported. Here's another study in Europe that studied 76 patients, again with the ultrasound test, and they couldn't find blockages in any of their patients. So was this variability in the test from one center to the next? Was this variability in MS from different countries in Europe versus North America? How could this be explained? And it's continued to be the subject of investigation. Dr. Zamboni's team suggested that this variability was the result of the fact that different centers were using different techniques to find these blockages. So colleagues also in Italy decided to use the very same techniques that Dr. Zamboni and his team had used. So in essence, to try to fully reproduce their findings using the exact same methods and criteria and strategies. So that we couldn't really have discrepancy about different results based on different techniques. So they studied MS patients, 84 people, and controls, 56 people, and did not find any differences between the two groups. And amongst the MS patients, about half of them were found to have abnormalities and half of them didn't. They were followed over time. And the important thing from this paper, which was actually published last month in the medical literature in a prominent neurology journal, there was no difference between the CCSVI positive MS patients and the CCSVI negative MS patients in terms of their future clinical course. So it didn't mean that if you had vein blockages, your MS had been there longer or was more severe or is more likely to deteriorate over the coming months than if you didn't have these blockages. So I think we're in a situation now where a number of groups have independently been unable to reproduce Dr. Zamboni's findings. And I think that leaves us with some unanswered questions about the relationship between this CCSVI abnormality and multiple sclerosis. There have been centers that have actually gone ahead and started to put stents into narrow veins. And this was a prominent interventional vascular specialist at Stanford that was doing this a few years back. And unfortunately, there were a couple of adverse events that came out from their experience. So sometimes when patients get the stent, they put on a blood thinner for a period of time after the stent is done to prevent it from clotting up. And unfortunately, a patient had a fatal bleeding event inside the brain because of the blood thinner. And in another patient, the stent that was put into the jugular vein actually slipped out of position and it migrated into the heart. And it forced the heart surgeons to have to go in emergently to fish it out. So there was an unexpected complication that required heart surgery. So the university at that point decided that, we don't really know what's going on here. The procedures look risky, and they halted the procedures being done at Stanford. I think these kinds of experiences and the fact that other centers have not been able to reproduce Dr. Zamboni's findings has forced a little bit of rethinking about the CCSVI. And at the end, I'll come back to some of my thoughts about that. So I didn't want to take on the somewhat controversial subject of the use of medical marijuana for treating MS-related symptoms. I get asked about this in the clinic quite a bit by patients. As many of you are aware, it's been approved, marijuana has been approved for medical use in the state of Michigan since it was approved on a ballot initiative in late 2008. And it's a very common and obviously controversial subject in our field. So cannabis is a plant and commonly referred to as marijuana, and the flowering petals of the plant are what is usually smoked recreationally and therapeutically for many, many years. And it turns out that the biochemists have found many different compounds in marijuana that are in this cannabinoid family. And the one that people may have heard of most commonly is this compound called THC, or tetrahydrocannabinoid, which is the main psychoactive substance, the substance that makes you, quote, high when you smoke marijuana. And actually, chemists have synthesized this molecule, and it's available as a therapeutic agent. So this, also known as dronabinol, people know it as Marinol. Here's another cannabinoid that's called Sativex, and the extract of the plant, Canador. These are all commercially available preparations of derivatives of marijuana. So they've been used therapeutically for pain relief, for appetite stimulation in patients with cancer, and for other indications for some time. So the question is, what effect does using the natural plant product or synthetic product have on multiple sclerosis? So it's been described for many years by MS patients that people who use marijuana find that many of their MS symptoms are made less severe. So there's word of mouth reports that it helps a variety of different symptoms. It's really hard to know the extent to which it's being used in the MS population, but I found a little bit of literature to suggest that a small proportion of patients in the UK admit to smoking marijuana for their MS symptoms. And in a group of MS patients in Canada, the use actually is relatively high. So I think it's fairly common, and the fact that I get asked about it regularly in the clinic means that it's something that's on people's minds. Now, none of the synthetic compounds that I mentioned are licensed for use in MS. So you can get a prescription for the drugs I mentioned on the previous slide, but it's not approved by the Food and Drug Administration for multiple sclerosis. Although last year it was approved in the UK, one of these preparations for treating muscle stiffness or spasticity. So there are now medical studies that are being done to suggest that these synthetic compounds may be useful to treat symptoms. So, anecdotal evidence, widespread reported benefit. There have been mail surveys that are done anonymously, so people get sent a survey, they don't put their name on it, and if they're willing to discuss their marijuana use relative to their MS-related symptoms, suggest that in a high proportion of patients, symptoms of pain, symptoms of muscle stiffness, tremors, and even mood disruption, anxiety and depression are benefited subjectively by the use of marijuana. Other symptoms that perhaps less commonly improve with cannabis use include fatigue, sexual dysfunction, weight loss. There are even some people, but a fewer proportion of them, that think it helps bladder symptoms. Dr. Braley introduced you to the concept of clinical trials. There are different ways to evaluate the rigor of clinical trials. Class 1 evidence is the most rigorous, so it's a placebo-controlled blinded study, and there have been studies with the with the compounds in small groups of patients that suggest that it's beneficial for some symptoms of MS. Less rigorous evidence suggests that it helps bladder symptoms.